I would like to welcome everyone to this event and thank AdMeTech Foundation for their partnership with the New Bedford branch of the NAACP for prostate cancer awareness. We've been partnering together since 2016. Similarly to the last year, we will address prostate cancer awareness and care in the times of the COVID-19 pandemic. These two diseases disproportionately strike African American and Hispanic communities, and they have another common denominator. Prevention and early detection are critical for saving lives and eliminating health disparities. We are dealing with a pandemic where virus that continually changes and the possibility of new mutations make it challenging to predict what will be happening in the next few months. We have been in a race against time and an ever-evolving virus. Overall, I think that one of the things that we are here for this evening is to discuss prevention and to discuss health inequity. And in prostate cancer, we know that it strikes Black and Hispanic males at a different rate. It is detected later, and Black and Hispanic males have a higher rate by which they die from this preventable disease. My name is Andrea Garbarnes. I apologize, I didn't introduce myself. My name is Andrea Garbarnes, and I am the chair of the NAACP New Bedford branch's Health, Equity, and Well-Being Committee. Tonight, I am honored to co-host with Martin Bentz. Martin settled in New Bedford in 2015 after a 30-year career with the United Nations. He worked as a senior administrator for the UN peacekeeping missions in Morocco, the Democratic Republic of Congo, Eritrea and Ethiopia, Afghanistan, and Kuwait. In peacekeeping operations, he led efforts for the fair treatment of the host nations the UN was sent to support, and also for the equal treatment of troops from Africa and South Asia, which did not have the same resources as the Western troop contributing nations. Martin and his family chose to live in New Bedford because of the city's diversity and welcoming reputation. A true champion of human rights and member of the New Bedford branch of the NAACP, he has served on the New Bedford Human Relations Commission since 2018 and was elected chair of the commission in 2022.
Good evening. Thank you, Andrea. Thank you all for participating in this critical webinar promoting healthcare equity and the importance of early detection and prevention of prostate cancer. The importance of getting early prostate cancer screening is especially critical for men of color who have a higher risk. I want to share a personal story. My godfather, Martin, after whom I am named, had a partner of color. His name was James Shaw, both of whom I love very dearly. But 22 years ago, because of the lack of adequate awareness and missing early treatment, Jimmy died of prostate cancer. Nowadays, he could have gotten tested with PSA testing and treated much, much earlier and would have had a much longer life. I hope that all men listening to this webinar will reach out to a doctor to make sure they're tested. Your life can be saved. Tonight, we have many truly great and wise speakers. They all have essential information for us. Andrea, thank you. And I want to point out that Andrea is the Health Equity Chair of the New Bedford branch of NAACP and a true champion here also of equity-based care here in New Bedford. She organizes and hosts amazing equity awareness conferences, and she will introduce the next speakers. So thank you.
Thank you so much, Martin. The next speaker would be Audra Riding. She's a general counsel and legislative director for Senator Mark Montigny, the chairperson for the Senate Committee on Steering and Policy. Audra Riding is going to deliver remarks on behalf of Senator Montigny. Audra?
Thank you, Andrea, and good evening, everyone. I will keep my remarks brief. I see Chairman Cabral has joined us this evening. Mostly, I just want to say thank you and express the Senator's gratitude to both the NAACP and the AdMeTech Foundation for bringing this event here this evening. One of the things we know with many types of cancer, but in particular prostate cancer, is the importance of early detection. My family is a direct beneficiary of early detection. My uncle is a prostate cancer survivor. And through the fabulous work of the foundation and changes to clinical guidelines, my own father has benefited from their work as well. So I personally cannot express my gratitude enough towards you all, but also just wanted to make sure that through Senator Montigny, we just want to emphasize the importance of keeping up with your regular checkups and making sure that you understand the importance of early detection. And we have a wonderful panel here this evening. And so that's mostly just to say thank you.
Thank you so much, Audra. I understand that Representative Antonio Cabral has joined us. Representative Cabral is the chairperson, Joint Committee on State Administration and Regulatory Oversight, and a champion of the prostate cancer educational program for high-risk men, with the priority focus on African-American, Hispanic, and Latinx individuals. So without further ado, bring to you Representative Cabral.
Good evening, and thank you very much for taking me out of turn a little bit so I can say a few remarks to all of you. Let me begin by thanking tonight's organizers and panelists for hosting this event and bringing prostate cancer awareness to our community. I am proud of being part of the Massachusetts State Legislature, which set an historical precedent in recognizing prostate cancer as critical public health priority for men, and particularly men of color. Prostate cancer is the second most common cancer among men, and the chance of having prostate cancer rises rapidly after the age 50. Prostate cancer is also the second leading cause of cancer death in American men, behind lung cancer. We also know that prostate cancer develops more often in African-American men than in men of other races, and these men also tend to be younger when diagnosed. In Massachusetts, Black and Hispanic men are almost twice as likely to die of prostate cancer compared to white men. Prostate cancer mortality in Black men is 1.5 times higher than the state average, so 71.7% versus 47.4%. The disparity ratio in mortality highest in Bristol County versus Massachusetts. Bristol County is 1 times higher in Black men versus white men than in Massachusetts. It's 2.2 higher in Black men versus white men. So as you see, it's almost double in Bristol County, those statistics. This health disparity is unacceptable, and we know that the best way to address this disparity is by increasing awareness of early detection and destigmatizing cancer screenings. Prostate cancer can be a serious disease, but most men diagnosed with prostate cancer do not die from it. According to the American Cancer Society, the survival rate for prostate cancer when diagnosed and treated early is nearly 100%. The best thing we can all do is make appointments for prostate cancer screenings, even if we don't have symptoms. We know that routine screening offer an opportunity to catch it in the early stages. But for most of us, COVID-19 affected our medical treatment and our normally scheduled cancer screenings. Appointments were canceled and maybe never rescheduled. Now is the time to set a reminder and call your doctor to schedule your next screening. Reminding your friends, neighbors, siblings, and fathers that it is time for them to reschedule any canceled screenings, especially their prostate cancer screening. The more we talk openly about prostate cancer and screenings, the more we will destigmatize a screening that saves lives. We all need to be more proactive about our health. Together, we can lead by example in our personal lives and our communities. In doing so, we can eliminate the prostate cancer disparities between men of color and white men in our community and the Commonwealth. Thank you. And again, thank you for the organizers of this evening and the panelists. It's really happy to be here with you.
Thank you, Tony. That was a great statement. And now I am deeply honored to welcome to this forum an outstanding advocate for civil rights and equity in healthcare, Attorney Michael Curry. Michael Curry is president and CEO of Massachusetts League of Community Health Centers, which represents 52 health care centers in Massachusetts that actively support health care outreach through 314 practice sites throughout Massachusetts and serves over 1 million members of the public who are marginalized, underrepresented, and underserved. Since our local chapter of the NAACP is co-sponsoring this webinar, it is all the more appropriate to note that Michael Curry is the past president of the Boston branch of the NAACP from 2011 to 2016, and is on the board of the national NAACP since 2014. We know your advocacy is in high demand, and we are truly honored to have you join us today. Welcome, Michael Curry.
Thank you, Martin. Thank you, Faina, and of course, the New Bedford NAACP for having me. It is great to see you, Ms. Barnes, and then of course, want to give a shout out to President Ledbetter and all the members of the New Bedford NAACP. You'll appreciate this. I always say I'm glad so many people are woke and others are waking up, but some of us are insomniacs. So these issues around health equity, racial justice, that people are paying more attention to over the last 2.5 years post the murder of George Floyd and COVID-19, it's NAACP branches, units like the New Bedford NAACP that are insomniacs that have been doing this work for a long time, trying to raise these issues and bring some awareness. So one, I just want to acknowledge the grassroots community activists who we all owe a debt of gratitude for here and across the country. Two, prostate cancer, I can't really, follow Representative Cabral's powerful remarks to really set the tone for this conversation tonight around the data. The data speaks for itself. Higher rates of disease and higher rates of death, lower rates of diagnosis, all those things speak volumes for the work that AdMeTech and so many folks across the country are trying to address. I always like to start us with a quote by Rebecca Lee Crumpler. So for those who don't know who Rebecca Lee Crumpler is, she was the nation's first African-American female physician in 1864. So you think about the women's suffrage movement, you think about the end of slavery, entering Reconstruction. And I always say, Andrea, that she was a bad sister in 1864 to be a female physician. And her quote that she's known for, she said, "They seem to forget there's a cause for every ailment, and it may be in their power to remove it." So why is it that those numbers that Representative Cabral read are the reality? We need to realize that we have it in our power to remove it. And some of that is historic. Large numbers of Black and brown folks did not have health insurance here and across the country before Representative Cabral, before we passed health reform in Massachusetts with Chapter 58. So by the time they found out they had stage 4 cancer, prostate cancer, colon cancer, breast cancer, high likelihood that it would have been advanced by the time they found it out after an emergency room visit. That was just a historical minute ago, 2006. The Affordable Care Act, 2010, was just a historic minute ago that folks across the country finally had an insurance card that said that they could go and get a primary care provider and get seen. So I just want to ground us in Rebecca Lee Crumpler's quote when she warned us that they seem to forget there's a cause for every ailment and it may be in our power to remove it. I think that's where we are. How do we now figure out why people are disparately dealing with prostate cancer and why we're not diagnosing, treating, and saving their lives so that all Americans have a chance to survive prostate cancer. And that's why I'm glad to be here tonight.
We really appreciate your remarks, Michael, and I'm sure you can inspire us with maybe some more comments later on if we have time. So we appreciate your interjections at any time that you see you could add to the conversation. So thank you very much again. And now I'm very pleased to introduce Dr. Sean Wason to this forum. Dr. Wason is Assistant Professor of Urology at Boston University, specializing in minimally invasive urological surgery and patient care. Dr. Wason has authored and co-authored numerous articles in medical journals. And amongst his many specialties in urology, I was particularly interested in his focus on surgical management of benign prostate hyperplasia. So I'm interested in that. His expertise is in early detection and treatment of prostate cancer, and his research in quality care and patient education are most welcome in this forum. Dr. Wason, welcome. Thank you.
Thank you so much for the invite. It's my pleasure to be here to give you a talk on some of the advances in screening, diagnosis, and therapeutics of prostate cancer. This is the third forum that I've done, and it's been absolutely wonderful, the feedback that I've received. So thank you so much for the invite. I have no disclosures other than this is my grandfather, James Edward Wason, Ernest, as we called him. He grew up in Barbados and he died of metastatic prostate cancer. And, I'm not too sure if this is the reason why I, currently deal with and treat men with prostate cancer, but, had there been more options for early diagnosis, potentially he would not have, passed away. Today I want to go over some of the screening. What are some of the goals? Who do we screen? When? And why? Why do we screen? These are my two boys, Leo and Makayo, 5 and 7. This is the reason why I'll be screened in the next year with PSA. I'll be 45 next year. How do we make the diagnosis? What are some of the current imaging techniques that we use? What is the role for biomarkers? You may hear some of this when you're talking with your urologist, and then go over some of the treatment options for localized prostate cancer. I'm not going to go over metastatic or advanced prostate cancer. So what is the prostate gland? It's a small gland. It's usually about 30 grams. It's tucked in between the bladder and the rectum, and it's usually around 30 grams, but it can be enlarged in cases like BPH or enlarged prostate. It's part of the urethral channel. A lot of men, as they get a little bit older, the urethral channel will narrow, and that prevents some of the urine from getting out, and that's what causes a lot of the urinary tract symptoms that we have. Prostate cancer doesn't necessarily cause any urinary symptoms in its early forms. It's a reproductive organ. It contributes to semen, and like others have mentioned today, the goals of prostate cancer are really early detection. It affects 1 in 8 men in their lifetime. And we really want to maximize the detection of intermediate and high-grade cancers and really minimize the detection of non-life-threatening cancers. All this cancer is sort of lumped into one group, but they're different aggressive cancers. And the goal is to really decrease unneeded biopsies and treatment. We have a phenomenal society that we work with, the American Urologic Association. They come up with the guidelines, and there's a guideline focused specifically on early detection of prostate cancer. Anyone under the age of 40 can really log off. You really don't need to screen anyone under the age of 40. The patients that we really want to maximize screening, if you're in the ages 55 and 69, this is the group that will obtain the most benefit from screening. Anyone over the age of 70, if they're in great health, could be reasonable to screen. There are other reasons to check a PSA over the age of 70, but we don't necessarily screen everybody. When should we get the first PSA? I think at the age of 45, and I think we have to have a simplified message to our primary care doctors. And what I typically say is get one at the age of 45. If it's under 1.5, then that person can delay further screening until a little bit later. Anyone over the value of 1.5 really should be referred to a urologist. How do we find prostate cancer? Really two things. We use a blood test, simple blood test called PSA. prostate-specific antigen, and we do a digital rectal exam. It's done best in combination. If your primary care doctor hasn't done a rectal exam, feel free to ask him or her to perform a digital rectal exam. Perfect case, gentleman was 49, came in to see me, PSA was normal. This was about 6 weeks ago. I did a rectal exam and it was clearly abnormal. He's got an intermediate grade prostate cancer. So sometimes the finger can pick up prostate cancers that may be missed on the blood test. So the good thing about PSA, it's gotten a lot of bad press, but I think the good thing is that it's very sensitive to disease. So if the PSA is high, there's probably some sort of disease in the prostate. It means it's very sensitive. And so if there's prostate cancer, typically it'll be up. It doesn't necessarily mean that you have prostate cancer, but it just means that we need to look a little closer to figure out why the PSA is up. It's really one of the early biomarkers. We use it for screening. We use it for diagnosis. We use it after local treatment. We use it in the advanced stage, and then we use it in metastatic disease. So the PSA is just this number that you just need to know what is your PSA value. From a urologist perspective, I think mass screening is really in the past. We really want to do shared decision-making with our patients. I think screening can lead to PSA anxiety. This is true, can lead to some tests that may be invasive, like a prostate biopsy, but it does give us a lot of information. I think whoever gets screened is dictated by the primary care providers, and whoever gets biopsied is really often dictated by the treating urologist. So again, if the PSA is less than 1, normal digital rectal exam, you can really delay further screening down the road 2 to 4 years. If the PSA is in between 1 and 3 in a normal healthy male over the age of 45, then you want to do repeat testing at 1 to 2 year intervals. Anything over the 3 with a suspicious digital rectal exam, those are the patients where we want to consider prostate biopsy. So PNB, prostate needle biopsy. We may consider an MRI in the situation. If we have a high suspicion, then directly to prostate needle biopsy. Anyone that comes into my office will get this very quick, it's a transabdominal ultrasound. And really what we can do is we can identify what is the prostate size, what is the anatomy of the prostate. If the PSA is a little high, but the prostate's pretty large, that may just signal BPH and not necessarily prostate cancer. So this is a non-invasive test that you can look at the actual size. If we do deem that a patient warrants a biopsy, there's 2 ways that you'll hear that this is done. It can be transrectal or transperineal. Just different locations on where the samples are obtained from. We are trying to move towards the transperineal approach just because there's less risk of sepsis or infections with the transrectal route. But I would say that most urologists perform the transrectal ultrasound biopsy to access the prostate and get our samples. Lately, there's been a lot of talk about this new type of ultrasound called micro ultrasound, and it's got higher frequencies, and the pictures that we do obtain of the prostate are a lot sharper, clearer. We can identify abnormal areas. It's a lot less expensive than an MRI. You can follow patients moving forward, and I think that this is a promising modality that you'll hear more and more from in the future. We typically do 12 cores, 6 from either side in the peripheral zones of the prostate. And this will tell us what is the grade. This is very important. You have to know your grade, and it goes from 6 to 10. What is the volume of cancer in each core? What is the location? And to make it simple for our patients, we've now come up with a grade grouping. So it'll go 1 to 5, 1 being least aggressive, which is the Gleason 6, 5 being the most aggressive, the Gleason 9s or 10s. So it's also important to know what number are you if you are diagnosed with prostate cancer. Nowadays, we really want to get multiparametric MRI in the hands of treating urologists. And we're fortunate here in Massachusetts that there's very few patients that are denied for an MRI. So a patient comes in, they're diagnosed with prostate cancer. Typically, they'll get an MRI, and this is a really nice way to look at the anatomy of the prostate. Does it involve the lymph nodes, the bones, and then other structures around the prostate? Is there disease coming outside of the prostate into the seminal vesicles or the nerves that supply erections? This can be done pre and post biopsy. I think the ultimate goal that we should really push for in this area is that anyone that comes in with an elevated PSA really should get an MRI before a prostate biopsy. That would, I think, is the ultimate goal. We're not quite there yet. There's a scoring system that's done by a radiologist. This is called a PIRAD score. And really what we're looking for is a number 4 or 5. This suggests that there's higher grade prostate cancer. So if you have an MRI and it shows a PIRAD's 4 or 5 lesion, this is what we want to target. And we can target it very easily now by fusing the ultrasound with the MRI, and the MRI will highlight where we need to biopsy. So I think the gold standard is an MRI ultrasound fusion biopsy. And so if your urologist is offering this, I think that this is the way to go to target suspicious lesions in the prostate. Now, if you're diagnosed with prostate cancer, again, it's a wide spectrum from very low to very high risk disease. And so there's really 5 categories of patients with prostate cancer. Not all prostate cancer is alike. So your prostate cancer may be different than your brother's, may be different from your uncle's. So it's important to know a lot of the facts around your particular prostate cancer. We are using biomarkers a lot more readily in patients that are on that we're not too sure. Do they have prostate cancer or not? These can be blood, these can be urine, but they're pretty much used in all aspects of patient care. So you may have this in the pre-biopsy space prior to a rebiopsy if you've had a negative biopsy before. And it can also be used post-biopsy or post-treatment. We don't use this on all patients, but we really want to be selective for certain patients, mainly in the patients that have the low to intermediate risk disease. This is just one of the tests that we use, Oncotype DX. You do a prostate biopsy. There's a little sliver of prostate cancer, but it's low volume, it's low grade. I think that this patient needs active surveillance, doesn't need immediate treatment. We can send this, the actual cancer to this company, and they'll evaluate the prostate cancer to see what is the biologic aggressiveness of this prostate cancer. What is the likelihood that this patient will die of prostate cancer, it will metastasize, or if I took out the prostate, what is the likelihood of finding some more aggressive disease? And it gives you these numbers, and this is great to counsel patients moving forward. Traditional imaging after biopsy, you may hear of CAT scan, CT, or bone scan. We still use these, especially when the PSA is very high, but very quickly is this being supplanted by PSMA. So this is the gold standard test, prostate membrane specific antigen. It's a PET CT scan. It's like a functional CT scan. So this PSMA PET binds to prostate cancer cells, and then it will light up on this particular scan. So if there's any concern for disease outside of the prostate, especially in high-risk patients, we are getting the PSMA PET scan. Are the lymph nodes positive? If so, the cat's out of the bag, as they say. You may not be a candidate for local treatment. And it's really amazing. There was one study that was done abroad where they didn't biopsy any patients. The PET scan was positive, the MRI was positive, they forego the biopsy, and they offered these men surgery. All 25 men had prostate cancer. So we're wondering if this may be the future, but this is a phenomenal test, and we're really trying to get it into the hands of most patients. How do we manage clinically localized disease? It can either be surgery, so we remove the prostate. You can treat it with radiation. There's different forms of radiation, or maybe consider active surveillance. The patient doesn't need immediate treatment. For patients that are very low risk, so low likelihood that this disease is going to spread or cause any problems, we just want to put you on an active surveillance protocol. We won't treat you immediately, but we'll use biomarkers, prostate MRI, ultrasound fusion, just to make sure there's no other disease that we missed. This is to avoid a lot of the side effects of treatment, erectile dysfunction, urinary incontinence. These are issues that are real issues that we know. We've probably over-treated a lot of men for prostate cancer. And so active surveillance, you'd want to consider if the disease is slow growing, if someone has a very low life expectancy, and it really avoids the side effects of treatment. Can you still get treatment? Absolutely. And really, we just base this on disease progression. So if the Gleason 6 goes to a Gleason 7 or higher, that's when we would pull the trigger to say, hey, now may be a good time to consider treatment. Can it grow or spread? Yes, but fortunately, prostate cancer tends to go pretty slowly. We usually, if someone's on a protocol and we're seeing them every 3 to 6 months, then we'll usually find the cancer early where it can be treated. What are the risks associated? A lot of people will just say, hey, I'm tired of the biopsies. There is some risk with the biopsies, and there's also some anxiety of knowing that you have some cancer that could have some aggressive potential. The intermediate risk patients are the ones that we would consider surgery or radiation. There's external beam radiotherapy, and this is done over a number of sessions. Brachytherapy is seeds, implanted seeds into the prostate, radiation that's given locally that dies out over time. And then there's other technologies like CyberKnife, where it's more intense radiation, but in a shorter amount of session. And so usually we're combining radiation with hormone deprivation therapy. So we're lowering testosterone in men, and we're treating them with the low testosterone and the radiation that has been shown to improve radiation. Intensity modulated radiotherapy is radiation. We're giving different boosts of radiation to different areas of the prostate. And we really want to minimize damage to other structures like the bladder and the rectum. This is brachytherapy. It's usually a combination between a radiation oncologist and a urologist to put the seeds in. Again, your prostate anatomy has to be such that the prostate is small without a large median lobe. This is the CyberKnife. And I would say the standard of care nowadays is to put this particular gel, it's polyethylene glycol hydrogel that's placed in between the prostate and the rectum to separate those two areas. It lasts only for about 3 months. So it really virtually eliminates any kind of rectal injury from the radiation. So this is a sort of a quick procedure. It's done in the outpatient world. What are the side effects of radiation? Fatigue. You can have some irritation of like the urinary system, the bowel. You can get erectile dysfunction, but this is something that usually happens later on. Surgery is very difficult after radiation if the cancer occurs. So we really do not try to offer radiation in young men. I typically, in my head, I think under the age of 70, if I can get them to surgery, that's probably the way to go. Anyone over the age of 70 with a lot of medical comorbidities, I would consider radiation. Prostatectomy is just removing the prostate. We really want to do it delicately to take it out and just preserve the nerves if possible that lead to erection. And I would say nowadays, the urinary incontinence that we used to see in the open prostatectomy, fortunately, we don't see it much anymore. There is some risk of urinary incontinence, but I think it's a lot less with our current techniques, which is the minimally invasive Da Vinci platform. Patients literally spend less than 24 hours in the hospital. They have 6 keyhole incisions. They don't need narcotics. They go home with a catheter for 7 to 14 days afterwards. And patients do really, really well with the Da Vinci platform. I would say that 99% of our prostatectomies done at Boston Medical Center are done with the Da Vinci robot. So quick recovery, pain is minimal, obviously a risk for major complications, but usually these patients are very well selected. Erections, I would say 50-50 whether or not you get a normal erection without medications. Most men will need some sort of medical therapy for erectile rehabilitation afterwards. Something else you may hear, high intensity focused ultrasound. This was FDA approved not too many years ago, but it's done a lot more robust treatment in Mexico and Canada, and it's come to the US. there's a lot of talk on focal therapy. I think this is where we're probably heading, especially with our new imaging modalities. If they're just a small focus of prostate cancer and half the lobe of the prostate, can we just eliminate that lobe? I think there's more to come, but I would say that here it's probably in its infancy for most patients. This was a phenomenal talk by Professor Laurie Klotz from University of Toronto. He came last week to give us a talk really on prostate cancer. And this guy's one of the biggest gurus of prostate cancer in North America. He spoke at the Massachusetts Association of Practicing Urologists, and he really went over from genetic testing to biomarkers. And I really like this slide. How can I be proactive after a prostate cancer diagnosis? This is a patient that has low-grade cancer that really wants to do everything possible to make sure that it doesn't progress. And he had really 4 things. Smoking cessation, number 1, probably the best thing you can do for yourself and your patients. That's number 1. Number 2, talk with your primary care physician about a low dose statin, vitamin D, and metformin. And here he's talking about this one particular, the mechanism of action of metformin. And this is really one of these wonder drugs. And so 4 things that, someone can do to prevent or at least delay aggressive prostate cancer. And there's, a lot of data for all these. So in summary, prostate cancer is common. Aggressiveness is quite variable. Early detection is favorable. So find it early and turn it into sort of a chronic condition. We really want to maximize detection of intermediate and high-grade cancers and minimize detection of low, non-life-threatening cancers. And now we have improved imaging, genomics that can improve risk stratification. And this really allowed patients to be a lot more comfortable with active surveillance. Very low and low risk disease, we consider active surveillance. Intermediate and high risk disease, surgery or radiation. And there are other treatments that are becoming more and more common. Patients are really demanding this. They want it, less invasive, but want to decrease the side effects of therapy. So thank you so much for the attention. It's been a pleasure. I agree with all the work that's been done here, and I think that my takeaway is that we're finding the disparities are less and less about genetics, but are really about access. And I think sessions like this really improve access, for patients. I think that this is a great resource for patients, and this was created by probably one of the foremost robotic surgeons in the Boston area called Well Prepped. And it really empowers patients to learn more about prostate cancer and urologic diseases. And Dr. David Keynes, who's at Leahy Clinic, sends this out to all of his patients beforehand. So you come to your visit armed with questions and information, and you know a lot more about your disease. So thank you for your attention.
Well, thank you, Dr. Weiss, and that incredible review of all the treatment advances that are going on in urology, and especially how you take care of the detection of prostate cancer. It seems to me, if I can take it from a layman's point of view, early detection is the most critical part of it. And for all of us, that's what we want to make sure all our male, in this particularly males of color, have access to early detection. Know that it's a simple PSA test or a simple visit to their primary care doctor to talk about it, and then go on with the detailed work that you are doing.
I think that's a fair assessment. If you wanted to avoid the digital rectal exam, fine, but I would say at least get one PSA. And they looked at the data, patients coming into the system with a PSA under 1.5. 80% of those patients will have a PSA under 1.5. Really, 20% are the ones we have to focus on. So hopefully you're in that sort of 80%.
And it's making sure that our population knows that it's as simple as that, and they have access to just go and get a simple simple blood work. rather than feeling that it's a major procedure and there are all kinds of psychological barriers to taking the next step. We want to try and make it as accessible, both in terms of like the health centers that Michael Curry is leading, so that people would be able to know that it's a simple procedure, necessarily going to the extent that you are advancing in your research and treatment, which is phenomenal, and I think welcome to all of us. Now I'd like to go on to the next and last presenter. It is my great pleasure to introduce the founder of AdMeTech Foundation and sponsor of this important webinar, Dr. Faina Stern. Dr. Stern founded the AdMeTech in 1997 with groundbreaking work in prostate cancer research, education, awareness, and advocacy. She is a tireless advocate for prostate cancer awareness and for reducing health disparities in African American, Hispanic, and Latino men. Because of her extraordinary work and research, she was named Woman of Excellence in 2016 by the Boston Business Journal, and she has received numerous rewards and accolades for her work, participating in multiple medical and scientific advisory boards, including the National Academy of Medicine, and then Vice President Biden at that time, Cancer Moonshot Program. Dr. Stern continues to shoot for the biggest goals in prostate cancer awareness. And thank you, Dr. Faina Stern, please.
Thank you so much, Martin. I would like to, first of all, thank everyone here, particularly Sean Wason, who was kind enough to volunteer his time tonight. And he very eloquently described the advances he described literally we've seen over the last 5-6 years that became standard. And I will focus on the program we recently established, which is called Prostate Cancer Equity Program. And unlike our past programs, including this event dedicated to prostate cancer awareness, the goal of Prostate Cancer Equity Program is to improve access to the most advanced, the least invasive, and the most effective diagnosis and treatment of prostate cancer. This primary focus, this program is available to everyone, but our primary focus is on Black, Hispanic, and Latino men. Because of so many technical difficulties we encountered in our many events, as a matter of rule, we started pre-recording my presentation. And Emma, or Trisha, do you mind starting my presentation? My name is Faina Stern. I'm a physician and founder of the AdMeTech Foundation. I'd like to express my gratitude to New Bedford NAACP for the long-term partnership since 2016, including this event. Also, I'd like to thank AdMeTech staff who made this event possible, Thomas Satam, Emma Coyer, and Trisha Kinney in particular. AdMeTech Foundation provides leadership for the groundbreaking programs in prostate cancer at the state, national, and international levels. Our programs have been transforming patient care for everyone and reducing health disparities in Black men. Dr. Wason reviewed recent advances in screening, diagnosis, and treatment of prostate cancer. I will describe our new prostate cancer equity program, launched recently, to bring these exciting advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate Cancer Equity Program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. We are grateful to the New Bedford delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age 50 and older. This program was initiated since 2009 in collaboration with multiple organizations, and has three components: public awareness, community education, medical education, and research. New Bedford and Bristol County have been a continuous areas of our concern. If we look at the current data from the Massachusetts Cancer Registry, we can see that Bristol County leads the state in prostate cancer incidence in Black men, or how commonly prostate cancer is diagnosed in Black men. The frequency of prostate cancer diagnosis in Black men here is almost 2.5 times higher compared to white men. Unfortunately, Massachusetts Cancer Registry or other sources such as National Cancer Institute do not have reliable data on prostate cancer mortality in Bristol County or how likely Black men can die of this disease. Unfortunately, we can guess if we take into consideration the mortality data previously reported between 2006 and 2009. At that time, mortality data in white men was actually lower than state average. However, prostate cancer mortality in Black men was 1.5 times higher than state average in Black men. If we look at health disparities, Black men were over 4 times more likely to die of prostate cancer in Bristol County compared to white men. The disparity factor in Bristol County was almost twice as high compared to state average in Massachusetts at that time. We do not have reasons to believe the situation got much better since that time. For public awareness and education, our messaging centered on the importance of screening and early detection critical for saving lives. In 2015, jointly with Brockton NAACP and Good Samaritan Medical Center, we focused on Plymouth County, which led the state Black men's mortality together with Suffolk County. As of last year, Black men's mortality dropped significantly in Plymouth County, where we have undertaken an extensive awareness campaign. We hope to work with New Bedford, NAACP, and other local organizations and community leaders to make a difference in Bristol County, similar to what we have done in Plymouth County. For public awareness and education, we had reached well over 36,000 men since January 2020. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable concern of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits, telehealth, ongoing in-person care, doctor's appointments and testing, and medical procedures such as biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men in our country. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only about 28% of men remain alive during the same time. In prostate cancer, screening with blood tests called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. If we look at the reduction of mortality per year, PSA blood test is the most successful screening tool we have had in the history of cancer. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly in a brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam, you need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors I just mentioned. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. The centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 6th annual conference took place this year between September 22nd and 24th. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices. This educational event showed rapid advances in patient care. In screening, our summit supports clinical guidelines for early detection recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. As mentioned, high-risk men, including men with a Black heritage or family history of prostate cancer, are recommended to start screening at the age of 40. Average risk men should start PSA screening at the age of 45. This first or baseline PSA result in younger men has emerged as one of the most important indicators for developing lethal prostate cancer long-term over 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. This non-invasive diagnostics, highlighting the importance of PSA screening, shifted past concerns about screening for prostate cancer into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsy and treatment, and optimize selection of personalized care for each man, including careful observation or active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality, dying of prostate cancer, and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, Black men are less likely to have precision diagnostics, such as advanced imaging, MRI, or molecular imaging, or genetic testing, or undergo life-saving treatment compared to white men. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. For example, in this slide, magnetic resonance imaging, or MRI, shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research development and large-scale clinical implementation of prostate MRI since 1998. Our summit highlighted the importance of MRI in Black men who are more likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics: MRI and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. Emerging data indicate the importance of genetic testing for many high-risk men, Black men in particular, for selecting the most effective treatment. With this precision diagnostics, we can now accurately determine if each individual man has a slow-growing, what we call harmless prostate cancer, or needs a careful observation, or an aggressive version of prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, PSMA molecular imaging has been approved by FDA within the last year and become available at the Dana-Farber Cancer Institute since August 2021. On the left, right here, we can see a traditional bone scale showing no metastatic spread. However, on the right, in the same patient, molecular imaging demonstrates extensive metastasis. This information is important for selecting appropriate and effective treatment. We are proud to have led research and development of molecular imaging since 2001. Based on the evidence coming from military medicine, from veteran administration, our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference with their multiple branches located across the state. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how a physician like me takes care of my family and friends. This process consists of 3 components. 1, AdMeTech Foundation's coordinator collects basic information and matches individual patients' need with the appropriate state's experts. A clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit. If an expert recommends any next steps, for example, additional testing or treatment, AdMeTech's coordinator and patient navigator work with men on the appropriate follow-up. To ensure successful implementation of this program, AdMeTech has created a network of leading state experts committed to eliminating health disparities, develop an effective process for patient care and follow-up, as mentioned, recruited community coordinators in high-risk areas who mobilized a network of over 100 program ambassadors, community, organization, and church leaders, held multiple focus groups to develop program materials. Our current goal is to identify and mobilize appropriate organizations and individuals so that men, their primary doctors and caregivers have access to this program. Trisha Keeney, a member of the AdMeTech Foundation staff, serves as a statewide coordinator for the Prostate Cancer Equity Program. If you have any questions or need assistance, please contact Trisha by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention. I just want to take this opportunity again to thank Mike Curry, administrator of NACP New England, our key for his support. This is our key partner, NACP NIC, and its multiple branches across the state, including New Bedford branch, that makes it possible for us to bring this kind of education and prostate cancer equity program to men in Massachusetts. Trisha, I also want to thank Representative Cabral, who's been a champion of this program for many more years that I can remember, and Senator Montigny. They have been outspoken supporters of this program and the funding for this program. Trisha, do you want to share, as a coordinator of Prostate Cancer Equity Program, do you want to say a few words why you're so passionate about your work?
Yes, absolutely. Hi, everyone. As Dr. Stern mentioned, I'm the coordinator of the Prostate Cancer Equity Program. So if you were to contact AdMeTech via email or phone call, I would be your first contact person. So the reason I'm so passionate about the Prostate Cancer Equity Program is because it acknowledges that finding healthcare, especially in terms of prostate cancer and navigating insurance, can be a strenuous process. So our goal at AdMeTech is to make sure that this process is as easy as possible for patients. As Dr. Stern and everyone else on this call mentioned, early detection is really important to save lives. So we really encourage screening, which is essential to prevent prostate cancer. So I encourage you and welcome you to join our program to get screened, even if you do not have symptoms of prostate cancer. And if you have questions about the program or would simply like to learn more, feel free to contact the email coordinator@admetechfoundation.org. And our website is also admetech.org, so you can read more about our program there. And I can put that in the chat as well. Thank you.
Thank you so much, Trisha. Once again, it's if we were to choose one call to action for today, is what we want to say. We have a network of outstanding physicians, including Dr. Wason, that we can match patients with. Our physicians were selected based on not only based on merit, but also based on their incredible compassion, kindness, understanding, and passion for reducing health disparities. The help is here. If you have any questions, starting with whether or not to get screening, please call Trisha, 617-523-3535. She will be able to get you connected with the best physicians in the state who can advise you whether or not to get screened, and about every option available today, best options available in medicine today. I think at this point, Martin, can we open for questions?
Yes, I think it's a wonderful idea if we could open the floor for questions, if we have any in the chat, but also any comments from our panelists. We had Michael Curry, if you wanted to add something, or Dr. Wason. We welcome your addition to the program.
Maybe just a quick comment. So excellent presentation, Dr. Wason, and appreciate Dr. Stern's presentation as well. You know, one thing to the doctors that concerns me, and I wanted to sort of broadly around where we are in the midst of this pandemic, is the screening numbers are down across the board for cancer. And we're seeing that in the clinical data. And there's a growing conversation around deferred care. The fact that so many people, I think it's 46% by the CDC, 46%, 47% of people deferred care during the last 2.5 years because of the pandemic, which means the diagnosis will be late if they get tested. And then the other part of that is that the systems are overwhelmed with the workforce crisis. So even if you wanted an appointment, even if you want to go see a specialist, all those appointments are now backed up as well within the various systems. I just wanted your thoughts around how do we, you know, it's one thing to tell people to deal with their fear, to give them the information on what they need to do to get tested. But then it's a whole other thing to deal with our systems and the COVID fear that that's created for some people to get care at all. So just wanted your thoughts on that.
Actually, Mike, within our prostate cancer equity program, we have an option for, first of all, we chose physician who would make Black, Hispanic, and Latino men their priority. So this man will not have to wait 2 months for an appointment.
Good.
Okay, so this is first thing I want to say, and it is particularly important right now when every emergency room and when every healthcare system is overwhelmed. Okay. Secondly, we also want to make sure. So basically, even if people have questions, it can be a telehealth appointment. It doesn't have to be particularly for initial consultation. It makes sense. Would they like this doctor? Would they trust this doctor? Would they be comfortable with this doctor before you will go perhaps see a doctor, which alleviates fear related to COVID. Okay, so many of our patients actually selected a virtual appointment first before proceeding with in-person appointment. Unless people were already told they have prostate cancer and they need close evaluation. Okay. Now, another thing is that why, you know, what I want to emphasize is it was important for us to reach out to the best doctors Massachusetts have and to the kindest doctors Massachusetts have, passionate about disparities, but it is also critical for us within prostate cancer equity program to make sure that men do not wait for the appointments too long, to expedite appointments as soon as possible, and for men not to feel alone. There will be AdMeTech coordinator they can contact with any questions or concerns. There is patient navigators. Patients are not left alone. We actually do not refer men to healthcare systems who did not designate a patient navigator that we can work with and men can work with. So it's really important for us that men's experience will not be the way it was in the past, particularly for men who don't necessarily from Black or Latino community, who do not necessarily have great trust or confidence in medical establishment. So I believe, Mike, that we came up with a solution that will be fundamental. Okay, the challenge right now is to make sure we will make this program, so actually men, primary care physicians, men's caregivers actually will know this program exists, that help is here. That's why I believe that call to action today is please beware, the help is here. Please contact Tricia and we'll take care of you.
I would echo Dr. Stern's comments that we really make a concerted effort. Anyone that comes in with a PSA over a certain value, we really, move that visit forward. We do offer televisits, especially to go over the biopsy results, and we've done it over COVID. We were quick to kind of switch to televisits, and we saw patients with elevated PSA. I really do think that screening, you're right, is down, and I think a lot of that had to do with the information that primary care physicians got. Initially, PSA had a bad rap for a long time. PSA got a D rating, and you go back to school and D is not good, and for good reason. I think that everyone was kind of lumped together. You had low risk, medium risk, high risk patients lumped into one, and it looked like we were not curing men from prostate cancer. But when you start looking deeper into the data and you pull out the patients with low risk disease, we really do make a difference in patients that have the low to high risk disease. And so they re-looked at the data. PSA is now a C rating, according to one of the task force that look at these. And I think we are starting to see an uptick with primary care providers really doing the PSA test. But there was a couple of years there where there was a lot of mixed information going out to the primary care doctors. But I think hopefully everyone's on the same page. Screening saves lives, and with the C rating and post COVID, hopefully those numbers will increase. I completely agree. There's an almost crisis in terms of workforce, not just healthcare, but a lot of industries. We are missing a lot of nurses and staff, and that is hurting us. But hopefully we'll get a little bit better.
We also have a question from Marcelina Pena Christian, who we have been working with since 2016 on prostate cancer awareness. And the question is, how will this video be acquired so that important resources can be shared with the community? And thank you for everyone's commitment. Marcy, we would love to come on your TV program with Dr. Wason. We would love to or anyone else here, we would love to inform men in Bristol County again, as you have done in the past with us. We can make it available to everyone, information about prostate cancer equity program, and we can provide link to this video on your TV program. We'll be happy to do that. If you are interested, we also will be happy to provide any information that you think appropriate for the website, social media of your TV channels, your mayor channels, so that men will know that help is here.
One of the important things, Dr. Stern, is that we can reassure men that the access is very easy. We know we can call Tricia, and that's great. And then we have also the virtual consultations, as Dr. Wason has mentioned. But it's then the next steps, going to actually see a doctor. There's the transport, there's the reticence. Do you have a way of actually reassuring our viewers that the access will be easy to get attention from a doctor?
We did not look into the issue of transportation specifically, but we assume that doctors will not be very far away from patients. We believe it is a reasonable assumption. It is also my understanding, Mike, please correct me if I'm mistaken, but it is my understanding that healthcare centers may have funding for transportation of patients to clinical providers. Is my understanding correct?
I think it depends on the health center. I think some have availed themselves of funding sources for transportation. But yes, I believe some health centers have access to resources.
Actually, Cheryl Bartlett, who is the CEO of Greater New Bedford Health Center, told us that she has transportation cost allocated to everyone who is interested in traveling outside of the New Bedford area to get consultation. So in New Bedford, it is not going to be an issue because Greater New Bedford Health Center can help. But I want to emphasize this program is open to anyone, any Massachusetts man, any man who resides in Massachusetts, who is 40 and older.
Excellent. Are there any other statements or questions? Andrea, would you like to say a few words?
Sure. To me, one of the The most important things that we can do is to continue to get the word out, continue to share this information, because as was shared this evening, that this is curable, that Black and brown men do not have to die or die at the high rates that they do. I will say that one of the factors that prevents some men in the greater New Bedford area for getting tested is, and it's not just getting tested as far access to healthcare, is that they are not employed in jobs that give them time off to be able to go to a doctor's appointment. So I know that there have been many men in my extended family that the reason why, along with the other factors, they just could not take that time off from work to get the testing. They could not afford to take that time off from work. And I think that sometimes that many of us forget that that's actually a privilege, that we can take a sick day and go to a doctor's appointment. And others who may be underemployed cannot, number one, they don't get a sick day, and they can't afford to lose that pay, even if they're not gone for the whole day. So I don't know how we work around that, but it is a problem. It is definitely.
I think, Andrea, this, once again, please contact us. We'll figure it out. Because if men are working at night, perhaps we can figure out the time that would work for them, at least for a virtual appointment to begin with.
Mhm.
And when the physician determines the risk and the need, then probably they cannot, you do not need to travel to get PSA testing. It's a well standardized test that can be gotten anywhere. Okay. I think it is resolvable, but it needs to be worked through on an individual basis. Representative Cabral?
On the issue of taking time off, actually, in Massachusetts, the legislature passed a law several years back that all employers, depending on the size, and I believe the size is 7 or more employees, but don't quote me on that, I could be off by a couple of employees, they must provide sick time for all employees. Even if they didn't offer before, they must put in place a program for their employees for sick days, for doctor's appointments, or even if they're just sick. There's a particular day that they don't feel well, they can call in and they will get paid for that day. It's paid sick time.
At least 7 days per year.
Yes, 7 days per year, state law, all employers have to, and I believe employers of either more than 7 employees or 10 employees must provide that. But we'll double check how many employees, and in case, Andrea, if you want to know exactly, we can follow up if you contact us exactly how many employees that an employer has to have in order to offer that.
If any man is afraid to talk to their employers, we'll coach them how to talk to their employers.
And also we have
a physician.
And also we have paid family leave, paid medical family leave in Massachusetts as well, for your personal health or for family members. If you have a family member that needs to be taken care of.
Mhm.
By the way, that's a law that I fought hard and worked for many years, and we finally passed it. Most of that law that was passed was based on the legislation that had been filing for quite a number of years. So right now, and that's for long term. For example, if it's for your personal health, you can have as much as 26 weeks paid if you need to take time off for particular illness of yours. If it's for a family member or to take care of a family member, a spouse or mother or father, then you have up to 12 weeks paid. That's Massachusetts law. So in Massachusetts, that's not the case in all the states. I mean, we are very, very lucky because Massachusetts has been very aggressive in these areas, not to mention healthcare itself, like Michael mentioned earlier. So there are no excuses. So if somebody is saying that, we need to figure out who they work for, and if they don't have a program set up, depending on the number of employees they have, they're violating state law.
I would just make a comment where I did fellowship in Norfolk, Virginia Beach area, and I worked for a large urology group practice, and we had Saturday morning office hours 9 to 12, and this was for a group of patients that really couldn't make it during the during the week. And so there are groups out there that do come up with some creative scheduling, evening appointments. Haven't seen it too much in Massachusetts, but I think obviously if there's more demand, then I think that some groups can accommodate that.
This is a resolvable problem. When we had a patient for prostate cancer equity program who was afraid to take time off because there was some crunch at work, our physician, one of our physicians, called him at night at his convenience to discuss whether or not further evaluation or further visits are justified. But then he was able to go back to his employer to say, look, Dr. such and such, a very important doctor at such and such healthcare system, told me that I must come and see him. I cannot delay it anymore.
Martin, do you have any closing remarks?
Oh, this has been a wonderful experience for all of us and all of us who are listening in on this program. And I'm sure it'll be shared widely. It's available through Facebook at the AdMeTech site. But we want to thank all of our panelists and all the people participating, and we've learned from this wonderful panel of experts. And we hope it's helped guide all of us who have been watching and listening to this, and your family members, on how to access early detection and better health, specifically through this AdMeTech program. And so thank you very much. We are very, very grateful for this opportunity and this partnership with AdMeTech and NAACP. And we hope we'll get the widest distribution and availability. Thank you, Dr. Stern. If you'd like to also say something to close out, because we appreciate your.
I just want to get back to Mike Curry's concern about significant drop in screening during pandemic. It's horrendous. At some point, there were numbers bounced about, I particularly follow breast and prostate cancer, up to 60% in some places. There was drop in for breast and cancer screening, the two most common cancers. And Mike, NCI data just came out on October 25, state cancer profiles, and they showed the area that I watch particularly like a hawk is Plymouth County, because we have such an extensive program there. Last year in Plymouth County, as I showed, we had prostate cancer mortality roughly 20 men per 100,000 in Plymouth County, right? Which is half of national average, less than half of state average. But this year it is 25, and this encompasses 2020. And I think it is only a beginning of what we will see. And we are talking about area where we have such a strong, awareness program and such a strong community engagement. Okay, so we need to brace ourselves to do more awareness and more work than ever in order to counterbalance what pandemic has caused. We need to get back to greater vigilance than we ever had, particularly for high-risk men. So basically, once again, the help is here. Please call 617-523-3535. Trisha Keeney and I stand ready, and everyone at AdMeTech, our wonderful physicians, stand ready to help you.
And thank you, Dr. Stern, and looking across the people who joined us, Dr. Wason, Michael Curry, Tony Cabral, Andrea, thanks for being our co-host, and all of you. We're very grateful for this wonderful opportunity. Andrea?
Thank you all so much for the sharing of your time and your knowledge, and sharing your knowledge in such a way that I believe it will bring some comfort to those seeking help, whether it be the males or whether it be the females in the family, to share that information with male members of the family and to share that concern. We thank you very much and thank you again for the work that's about to be done in the city of New Bedford and in Bristol County.
Have a great evening. Thank you so much for your partnership. Thank you.
Thank you.
Take care, everybody. Good night.
Excellent. Great conversation. Thank you.
Thank you, Michael.